In today's video, we will cover physiology questions that test your understanding of cell signaling pathways and ventilation-perfusion relationships in clinical contexts. We'll explore how local mediators like histamine function and how gas exchange is affected in conditions like pulmonary embolism. So let's get started. A 40-year-old man with a sedentary lifestyle developed sudden onset shortness of breath and sharp chest pain during a long overnight train journey. He reports having had cramping pain in his left calf earlier that day, which he attributed to sitting for too long. He had been seated for over 10 hours without standing or stretching. Imaging confirms a pulmonary embolism obstructing the left pulmonary artery. Assuming ventilation remains unchanged, which of the following arterial blood gas abnormalities would most likely develop in the first few minutes after the occlusion? Now, this clinical scenario is a classic setup for a deep vein thrombosis. In this patient, the clot embolizes to her left pulmonary artery, causing abrupt loss of perfusion to her left lung, and the ventilation remains unchanged. This means one lung is ventilated but not perfused, resulting in an area of very high ventilation-perfusion ratio. So basically, this question assesses your understanding of ventilation-perfusion mismatch, particularly in the setting of acute pulmonary embolism and its impact on arterial blood gases. Now, the options given here are A, decreased partial pressure of carbon dioxide, B, decreased partial pressure of oxygen, C, increased partial pressure of oxygen, D, no change in partial pressure of oxygen or partial pressure of carbon dioxide, and E, increased partial pressure of carbon dioxide. Before we go through the correct and incorrect answer choices, let's first review what the ventilation-perfusion ratio actually means, because understanding this concept is the key to figuring out how a pulmonary embolism affects gas exchange. Now, a ventilation-perfusion ratio describes the relationship between alveolar ventilation, which is the amount of air reaching the alveoli, and pulmonary perfusion, which is the amount of blood reaching the alveoli via the pulmonary capillaries. The normal value is approximately 0.8, and this balance is essential for effective gas exchange, which means getting oxygen into the blood and removing carbon dioxide. A high ventilation-perfusion ratio means that there is ventilation without adequate perfusion, leading to dead space, and this happens in pulmonary embolism. And a low ventilation-perfusion ratio means that there is perfusion without adequate ventilation, and this happens in cases where there is airway obstruction, such as asthma. The correct option here would be E, and that is because the clot embolizes in the left pulmonary artery, causing a sudden loss of perfusion to the left lung. As a result, the left lung is ventilated but not perfused, creating physiologic dead space with a high ventilation-perfusion ratio. Carbon dioxide cannot be effectively cleared from the affected lung, and the right lung becomes overburdened. Because the question states overall ventilation remains unchanged, carbon dioxide excretion decreases, leading to an increase in partial pressure of carbon dioxide. Let's have a look at why the other options are incorrect. Option A is incorrect because decreased partial pressure of carbon dioxide might occur later if the patient increases minute ventilation as a compensatory response. However, this question says ventilation remains unchanged, so hypocapnia would not occur immediately. And Option B is incorrect because while ventilation-perfusion mismatch can lead to hypoxemia in isolated dead space, the effects on partial pressure of oxygen is less pronounced initially. And also, partial pressure of oxygen may be preserved early due to compensation by the unaffected lung. And option C is incorrect because there is no basis for increased partial pressure of oxygen because pulmonary embolism limits oxygen uptake, and you would never see partial pressure of oxygen increase after losing perfusion to part of the lung. And option D is incorrect because gas exchange is impaired. A 45-year-old man with a history of chronic gastritis reports experiencing upper abdominal discomfort after large meals. He notices that over-the-counter acid-reducing medications have helped alleviate his symptoms. His physician recommends a medication that blocks histamine 2 receptors to reduce acid secretion. In the context of gastric acid regulation, which of the following best describes how histamine reaches its target cells? Now, this question tests your understanding of the mechanism of histamine signaling in gastric acid regulation, specifically the mode of secretion or type of cell signaling involved. The focus is not on the drug's action, but rather on how histamine naturally acts in the stomach to promote acid secretion. The options given here are A. Autocrine secretion, B. Exocrine secretion, C. Holocrine secretion, D. Endocrine secretion, E. Paracrine secretion. The correct option here would be E, and that is because histamine is released by the enterochromaffin-like cells in the gastric mucosa and act locally on nearby parietal cells to stimulate gastric acid secretion by binding to H2 receptors. This is a paracrine mode of signaling in which the secretory product acts on cells in the near vicinity and reaches them by diffusion. Let's have a look at why the other options are incorrect. Option A is incorrect because in autocrine secretion, the secretory cell is also the target cell, in which a cell releases a substance that acts on itself. And option B is incorrect because exocrine secretion involves delivery of secretory product via the duct, for example, pancreatic enzymes. And option C is incorrect because in holocrine secretion, the entire secretory cells break down to release the product, for example, in sebaceous sweat glands. And option D is incorrect because endocrine secretory products are carried to their site of action in the bloodstream.